Good morning, all. The topic we are going to discuss is trauma from occlusion. So, what do you mean by trauma from occlusion? So, what is the definition of trauma from occlusion? It is defined as when the occlusal forces exceeds the adaptive capacity of the tissue injury results. So normally there will be an adaptive capacity of the tissue is there to withstand the occlusal forces. So when occlusal forces exceeds that adaptive capacity, the tissue injury results. So that tissue injury is known as trauma from occlusion. And the occlusal forces which leads to trauma from occlusion, that is termed as traumatic occlusal forces or traumatic occlusion. Classification of trauma from occlusion. There are various different classifications are there. Box classification 1930, trauma from occlusion can be classified as physiologic occlusion and traumatic occlusion. Glickman's classification 1953, according to the duration of the cause, trauma from occlusion can be classified as acute trauma from occlusion and chronic trauma from occlusion. According to the nature of the disease, again, it can be classified as primary trauma from occlusion and secondary trauma from occlusion. Fan and Caton in 2018 classified trauma from occlusion as primary occlusal trauma, secondary occlusal trauma, and occlusal trauma due to orthodontic forces. So these are the important classification related to trauma from occlusion. I'm going to explain in detail about the Glickman's classification. So based on that, according to nature of the disease, nature of the cause and the duration of the cause, trauma from occlusion can be classified as acute and chronic, primary and secondary trauma from occlusion. So what is acute trauma from occlusion? It results from an abrupt occlusal impact. For example, biting on a hard object, or there is a overhanging restoration or prosthetic appliances, there will be an abrupt occlusal change. So that can cause us acute trauma from occlusion. So in this acute trauma from occlusion, patient will have more clinical features or symptoms. The patient will be more symptomatic. So the clinical features are tooth pain will be there, sensitivity to percussion, increased tooth mobility will be there, and in severe cases of acute trauma from occlusion, it can cause us necrosis, periodontal abscess, and cemental tears also. So in this acute trauma from occlusion, patient will be symptomatic. Next type based on the duration of the cause, trauma from occlusion can be classified as chronic trauma from occlusion. So as the term implies, that is, it mainly occurs due to the result of gradual change in the occlusion. So the gradual change in occlusion is produced by tooth wear, drifting movement, extrusion of the tooth, mainly supraeruption, presence of various parafunctional habits like bruxism or clenching. So this occlusal gradual change in occlusion that results in chronic trauma from occlusion. So it is more common. Chronic trauma from occlusion is more common than acute trauma from occlusion. According to the nature of the cause, based on Glickman's classification, the trauma from occlusion can be classified as primary and secondary trauma. So what is primary trauma from occlusion? So the primary etiology factor is the alteration in occlusal forces. So when the traumatic occlusion or trauma from occlusion occurs as a result of alteration in occlusal forces, it can cause primary trauma from occlusion. For example, if there is an insertion of high filling, or if there is a prosthetic replacement, ill-fitting prosthetic replacement, a drifting movement or extrusion of the tooth into edentulous spaces, or if there is a orthodontic tooth movement. So all this will cause us alteration in the occlusal forces, which can leads to primary trauma from occlusion. Whereas secondary trauma from occlusion, it occurs when the adaptive capacity of the tissue to withstand the occlusal forces is impaired by bone loss resulting from the marginal inflammation. So in this case, there will be presence of periodontal disease or bone loss due to periodontitis. So that the adaptive capacity of the tissue to withstand that occlusal forces will be impaired. So in this condition, in the secondary trauma from occlusion, even with a normal occlusal force, the periodontium will become more vulnerable to injury. So these are the three different situations that deposits the if there is an excessive occlusal forces which can be superimposed. So in this diagram, first diagram, that shows the normal periodontium with normal height of the bone. That represents a primary trauma from occlusion. Whereas the second B and C diagram, that is normal periodontium with reduced height of bone and marginal periodontitis with reduced height of bone. So this two conditions represents the secondary trauma from occlusion. That means that in this case, there will be a bone loss or periodontal destruction that causes the impairment of adaptive capacity of the tissue to withstand the occlusal forces. So that is secondary trauma from occlusion. So what all effects are there? Effect of occlusal forces on periodontium. So this effect is mainly influenced by various factors like magnitude of the force, direction, duration, and frequency of the force applied. So based on this, all these factors, there will be changes will be happening on the periodontium due to the effect of occlusal forces. So the influence of this trauma from occlusion on the progression of periodontal disease have been studied by various authors. And the main concept regarding this influence is mainly Glickman's concept and Verheyen's concept. In these two concepts, Glickman concept that shows a favorable influence or a positive influence of trauma from occlusion on the progression of marginal periodontitis, whereas Verheyen's concept is a contradictory concept that doesn't show any influence of trauma from occlusion and progression of periodontal disease. So based on this Glickman's concept, mainly it is put forward in year 1965, 1967. So based on this concept, there are two zones are there. So you can see this zone of irritation and zone of co-destruction. In this diagram, you can notice that zone of irritation mainly confined to marginal gingiva and interdental papilla, whereas zone of co-destruction, it is involves the underlying supporting structures like periodontal ligament and alveolar bone. So as long as the inflammation is confined to the gingiva, the inflammatory process is not affected by the occlusal forces. So the zone of irritation is not affected by the occlusal forces. But when the inflammation extends from the gingiva into the supporting periodontal tissues, the plaque-induced inflammation enters the zone which is influenced by the occlusion. So that condition where the zone of irritation is changed to zone of co-destruction. So that leads to destruction of periodontal ligament fibers and alveolar bone. So based on this Glickman's concept that shows that the pathway of spread of a plaque-associated gingival lesion can be changed if the force of an abnormal magnitude are acting on the teeth harboring the subgingival plaque. So mainly based on this Glickman's concept, I have already told you there are two zones are there, zone of irritation and zone of co-destruction. Zone of irritation is confined to marginal gingiva and interdental papilla. So if there is only marginal inflammation that is not influenced by trauma from occlusion, whereas if the inflammation spreads to the underlying supporting structures, then that will be influenced by trauma. So that case, the zone of irritation is changed to zone of co-destruction, where it affects periodontal ligament, root cementum, and alveolar bone. That is trauma-induced. So this is about the Glickman's concept. This is one of the important concept which shows a positive influence of with trauma from occlusion and progression of marginal periodontitis. The another important concept I have told you, already told, that is Verheyen's concept, that is a contradictory concept. So based on this concept, the loss of connective tissue attachment or a resorption of the alveolar bone or periodontal destruction is exclusively occurs as a result of the inflammatory lesion associated with subgingival plaque. So there is no influence of trauma from occlusion. It's mainly due to presence of subgingival plaque. So the angular bony defects or the supra-bony, infra-bony pockets that are usually occurs due to the presence of plaque, it is not affected by the trauma from occlusion. So this is a contradictory concept that doesn't show any influence of trauma from occlusion and progression of periodontal disease. In addition to this Glickman's concept and Verheyen's concept, there are various other theories which shows a relationship between traumatic occlusion and progression of periodontal disease. So all these theories that shows that trauma from occlusion may alter the path of extension of gingival inflammation into the underlying tissues. And other theory which supports that trauma-induced areas of root resorption, which is uncovered by the apical migration of inflamed gingival attachment, that may offer a favorable environment for the plaque accumulation or calculus formation. So in that case, if there is a traumatic occlusion, so that will result in more plaque accumulation or calculus formation. And another theory deposits that the supragingival plaque will become a subgingival plaque if the tooth is tilted orthodontically or migrates into an edentulous area. So that condition, the supragingival plaque will become a subgingival plaque. So if there is a suprabony pocket, that will be converted to infrabony pocket and there will be progression of periodontal disease. So that is also another theory which shows a relationship between trauma from occlusion and periodontal disease. And one more theory is there that shows that if there is an increased mobility of a traumatically loosened tooth, so that may have a pumping effect of the subgingival plaque metabolites deeply into the periodontal pocket. So that will also leads to progression of periodontal disease. So all these theories, in addition to Glickman's concept and Verheijen's concept, these theories also will prove that there is a relationship between trauma from occlusion and progression of periodontal disease. So next part is the important part, that is stages of trauma from occlusion. So based on this traumatic occlusion, there are various tissue response can occur. So this tissue response can be categorized under 3 stages. Stage 1, injury; stage 2, repair; and stage 3, adaptive remodeling. So what is injury stage? If there is a traumatic occlusion or if there is a force of occlusion, the tooth will rotate around a fulcrum or axis of rotation. So usually in a single rooted tooth, that axis of rotation mainly seen midway between the middle third and cervical third of the root, whereas in the multi-rooted tooth, it is seen on the furcation area. So during the traumatic occlusion, there will be formation of areas of pressure and areas of tension on both sides of the root. So there are certain changes, periodontal changes will occur on the areas of pressure and areas of tension. Even if it is a slight excessive pressure, slight excessive tension, or greater pressure or greater tension. So what all changes can be occurring on periodontium if there is a slight excessive pressure or slight excessive tension? What all changes can occur on areas of pressure and areas of tension? So these are the changes what is happening in the pressure side if there is a slightly excessive pressure. So there will be resorption of the alveolar bone, widening of the periodontal ligament space, and the blood vessels will be reduced in size. And in tension side, the changes are, if there is a excessive, slightly excessive tension, the changes are elongation of the periodontal ligament fibers, apposition of the alveolar bone, and the blood vessels are enlarged. So these are the changes what is happening on the periodontium if there is a slightly excessive pressure and slightly excessive tension. These are the changes what is happening on areas of pressure and areas of tension. Whereas if there is a greater pressure and greater tension, severe tension, these changes, certain other changes will be seen on the areas of pressure and areas of tension. So greater pressure, if there is a greater pressure, there will be hyalinization or compression of the periodontal ligament fibers. There will be necrosis, there will be vascular changes, there will be increased resorption of the alveolar bone or resorption of the tooth surface. Root resorption can occur. So if there is a greater pressure, so these changes will be seen on the areas of pressure. And if there is a severe tension, the what all changes can be seen on areas of tension. So there will be widening of the periodontal ligament, thrombosis, hemorrhage, tearing of the periodontal ligament, and instead of bone formation, there will be resorption of the alveolar bone. So this is what is happening in stage 1. These are the tissue response, what is happening in stage 1 or injury stage. There will be formation of areas of pressure and areas of tension, and there are certain changes, periodontal changes can be occurring on areas of tension and areas of pressure during slightly excessive pressure, slightly excessive tension, or greater pressure or greater tension. So next tissue response after the injury stage, next tissue response is stage 2 or repair stage. In this stage, there is an attempt to restore the lost periodontium or lost bone. So in order to attempt or in order to restore that periodontium, the damaged tissue are removed and the new connective tissue cells, fibers, bone, and cementum is formed. So if there is an excessive occlusal forces, you know that there will be bone resorption in injury stage. So to compensate that bone loss, there will be bone formation will be occurring. In order to compensate for that lost bone, there is an attempt to reinforce or restore the injured periodontium. That type of bone formation, that is known as buttressing bone formation. So that is seen in repair stage, stage 2, buttressing bone formation. Mainly two types of buttressing is seen, central buttressing and peripheral buttressing. Central buttressing occurs within the jaw, that is bone formation occurs within the jaw, and peripheral buttressing, that is the bone formation which is seen on the outer cortical plate, either facial or lingual cortical plate. If the peripheral buttressing occurs on the facial cortical plate, it sometimes it appears like a shelf-like thickening of the alveolar margin. So that type of shelf-like thickening, that is termed as lipping. So this is what is happening in stage 2 or injury stage, that the stage 2 or repair stage. So that is there is an attempt to repair or attempt to restore the lost tissue, or attempt to compensate the lost bone. There will be bone formation. That type of bone formation is known as buttressing bone formation. So that is what is happening in stage 2 or repair stage. Next stage or tissue response, that is categorized as stage 3 or adaptive remodeling of the periodontium. So in this stage, adaptive remodeling, there is a there is an imbalance. There is an imbalance in the equilibrium between injury stage and repair stage. That means if the repair cannot pace with the destruction caused by the occlusion, then the periodontium itself will get remodeled to get adapted to that occlusion. So there are certain remodeling changes will occur in the periodontium. So that is known as adaptive remodeling of the periodontium. So these are the remodeling changes, what is happening in the periodontium to get adapted to that traumatic occlusion. Uh, the remodeling changes are thickening of the periodontal ligament, that is funnel shaped thickening at the crest, alveolar crest. There will be formation of angular defect or vertical defect. There won't be any pocket formation. There will be increased vascularization. So with this remodeling, that periodontium itself get adapted to that withstand the occlusal forces. So these are the various tissue response. What is happening if there is a traumatic occlusion? The tissue response are categorized under stages, 3 different stages. Stage 1 is injury stage, stage 2 is repair stage, and stage 3 is adaptive remodeling. So stage 1, injury stage, there will be formation of areas of pressure and tension. There are certain changes are occurring on both sides, areas of pressure and areas of tension. And stage 2 is repair stage. In that stage, buttressing bone formation is seen. Either it can be central buttressing or peripheral buttressing. Stage 3 is adaptive remodeling. In that stage, the periodontium itself get remodeled to get adapted with the traumatic occlusion. So these are the 3 stages or tissue responses. Next next topic is clinical signs of trauma from occlusion. So the patient will have certain clinical signs and symptoms, that is mainly increased tooth mobility and migration or drifting of the tooth. And Fremitus test, this is the diagnostic test for trauma from occlusion. That is, the finger is placed, index finger is placed on the labial aspect of maxillary anteriors, and ask patient to close the mouth with maximum indecuspation so that we can feel the vibration on our fingers. So that Fremitus test will be positive in trauma from occlusion. There will be persistent discomfort on eating. There will be occlusal prematurities, presence of varices, chipped or fractured tooth, and there will be hypersensitivity to hot and cold foods. So these are the clinical signs of trauma from occlusion. Radiographic signs, there will be discontinuity and thickening of the lamina dura, widening of the periodontal ligament space, and there will be funnel-shaped or saucer-shaped thickening of the alveolar crest, radiolucency or condensation of the alveolar bone, and root resorption is also noticed in radiographs. Next part is the treatment part. So if there is a traumatic occlusion or if there is a trauma from occlusion, how to manage the traumatic occlusion? If there is an occlusal discrepancies, we can manage with occlusal adjustment either by doing selective grinding or coronoplasty. And if there is any presence of any parafunctional habits like bruxism, clenching, so we have to manage that. Then only we can manage the traumatic occlusion. And if there is a mobile tooth, if it is a grade 2 mobility is there, we have to stabilize the mobile tooth either by temporary, provisional or long-term stabilization. And if there is a drifting or a supraeruption on the edentulous area, if there is a unreplaced missing tooth, we have to correct the traumatic occlusion by replacement of the missing tooth, either with removable or fixed appliance, or even with implant therapy. And if there is a malalignment or a tooth displacement, so drifting of the tooth and all, we can correct the traumatic occlusion by doing certain orthodontic tooth movement. And also we can go for a occlusal splints also in case of bruxism and all. So these are the various treatment approaches for the management of traumatic occlusion. So these are the important contents we have to read from this topic, trauma from occlusion. Mainly, what is the definition of trauma from occlusion? How can we classify trauma from occlusion? Mainly the Glickman's classification. Based on the Glickman's classification, uh, acute and chronic trauma from occlusion is there. Primary and secondary trauma from occlusion is there. What all clinical features are there, radiographic signs are there, what all tissue response that can be categorized in 3 stages: injury stage, repair stage, and adaptive remodeling stage. And is there any influence of trauma from occlusion and progression of periodontal disease? That is proved by various concepts, mainly Glickman's concept and Wareham's concept. So these are the important contents we have to read from this topic. Thank you.